Okay, আজকে recall hello, assalamu alaikum. So today we will start recall as well as cardiac catheterization is remaining that we will discuss later. So first of all, I want to start recall. Here I know that all of you are here eagerly waiting for recall, and because your exam is knocking, and I am also very much eagerly waiting for this session because it is, it's also very brainstorming for me also, and I enjoy recall session. So first of all, I just want to say that here you have to be very much active, and you should not think that only line by line from recall the questions will be. So in the question paper, you maybe find it different. So don't take it always, the questions will be same to same as recall. This is the things that I want to give this information to all of you so that you can take preparation by this way. Okay? And you should know that sometimes it is very different from other questions, and they are making their exam system difficult, or I think more, they want to try it, make not in their sense more difficult, rather than I should say that they are trying to make it more so that they can pick up more students, those who are they have more understanding, more clinical orientation. So their aim is like this. So my request that you will read the recall very, very right, but you will check that you understand that these things or not. Okay. So there is a very, when you have any problem, so you can find it from the PDF, and there you have to read it. And always I say that you have to revise your whole recall paper at least 3 times before exam. I like this way, so you can try these things also. So let us start. So from September 2000, actually it is not from September 2023. There is January also here. Yes, from January also here. So although it is written here September 2023, but after 4 to 5 questions you will get January. Okay, I will change it later. So first questions, if you check, then easy question. Patients, so what you will do, you will try to answer, you try to write it, okay? So that you can understand that how much you having grab on this. And I try to cover 2023, 2024, and if anything important remaining. Okay. So patient with hematuria, 2 days after sore throat infection, he has second-degree relatives of deafness. So you see, after 2 days of upper respiratory infection, got hematuria, second-degree relatives of deafness, blood pressure 80/50, other vitals normal. Yes, normal urine outputs, EBC normal, ASO titer raised. It shows urea normal, creatinine 66. So high creatinine, C3C4 normal, IJ is 28 in the upper normal limit. Urine analysis, protein, blood, no cells or nitrate. So what's the diagnosis here? What do you think? Cells there. Okay. So when we get that Alport syndrome, we know that IgA nephropathy having, how the IgA nephropathy presentation after throat infection, they got this hematuria. They could have C3C4 normal, okay? And ASO titer is not significant. Their creatinine, all the GN features would be there. And but it is recurrent. Usually IgA nephropathy having recurrent. Alport syndrome could have deafness along with, they could have, C3, C4 normal, and also they could have high creatinine and other things. If they give age, then it would be more helpful for us, but it's for sure it's not like UTI, renal calculi, and post-streptococcal glomerulonephritis. So post-streptococcal glomerulonephritis will not be 2 days after. So here actually, we difficult to things to pick it up. Only there is he has second degree relatives of deafness. It is not even first degree, but second degree relatives of deafness. Otherwise, we have high creatinine and hematuria, proteinuria. A child having, Alport syndrome can be presented with high creatinine, but IgA nephropathy presentation usually not with high creatinine. So in that sense, you have to take it here, Alport syndrome, but you will get some other questions. That is, in that cases, it would be, the presentations other than deafness, you will get the IgA nephropathy features. So what is the difference here? So one of the important things is for Alport syndrome, there could be family history of deafness, or child could have some deafness or visual problem, and also you can get the GN features. And IgA nephropathy will be after upper respiratory infections, the GN features. Okay, but IgA nephropathy is a recurrent hematuria. Alport syndrome also could have recurrent hematuria. So it is also their similarity. But IgA nephropathy with the presentation usually not with the high creatinine. So Alport syndrome, I'm now telling it Alport syndrome, but be careful that what the age. So if they ask you only one things and the patient age is, it is 12 or 13 years, and only there is a second degree relative deafness, in that cases, I think you should go for IgA nephropathy, because IgA nephropathy is presented usually at the adolescence age. Okay, so I'm not very much satisfied. Only for the deafness history, we can take always Alport syndrome. Do you get my point? So here I'm taking Alport syndrome because they didn't say me that there is recurrent hematuria and this is the first time. And also the creatinine is at the initial presentation high, and IgA level is normal here. So all the things put me to the Alport syndrome, but it could be IgA nephropathy as well. So other, when we go for the other questions, I think it will be more clear to us. Okay. 8 months old infant boy complains of faltering growth, constipation, which is not improved on laxative despite changing many types of formulas. Sodium 135, potassium 355, phosphate is low, 0.8 only, glycosuria, proteinuria, high PTH, high alkaline phosphatase. So child having constipation may be due to hypokalemia is not there. So 8 months constipation, but problem is hypophosphatemia, glycosuria, proteinuria. So what do you think that when the this hypophosphatic, glycosuria, proteinuria, high PTH, high alkaline phosphatase, along with low phosphate could be there? So usually PTH become normal in case of one specific condition. Na? When there you will get phosphaturia, but here there is no phosphaturia. Anyone commenting here? It's new comment. So so here we are wants to go for cystinosis. When hypophosphatemic rickets, then we get low phosphate, but mainly urinary phosphate will be high, and also PTH will be normal. Okay, so PTH high also could be, but in this context, their main things is not the rickety changes or something like this. And also glycosuria proteinuria is there. Glycosuria proteinuria force us to go for cystinosis, which is a part of proximal renal tubular acidosis. So we can think of cystinosis. So in that cases, it would be cystinosis, but not renal artery stenosis. Renal artery stenosis is not any option. Celiac disease also could not be. 6 months old, recent history of vomiting and tetany, low sodium, low potassium, metabolic alkalosis, and pH is 7.49. So what is the diagnosis? Recent history of vomiting and tetany. There is low sodium, low potassium, and metabolic alkalosis. So what is the diagnosis? So you see that it is again hypokalemic metabolic alkalosis. Okay, and only 6 months. So hmm, I can see that it wants to go for C. So why not pyloric stenosis? So pyloric stenosis is not 6 months presentation. It is usually 4 to 6 weeks presentation, and also they have vomiting with weight loss, and they give some characteristics of vomiting, goes outside or something like that. It's not associated with any tetany. Tetany indicate that metabolic alkalosis. But it was, in the pyloric stenosis, not presented with this tetany or something like that. Okay, so cystic fibrosis patient having hypokalemic metabolic alkalosis, it's also called pseudobarter, but they will having, some history of cystic fibrosis, otherwise very difficult to say. Renal tubular acidosis will be metabolic acidosis, not metabolic alkalosis, so we can go for Bartter disease. Now, 5 months baby with Proteus UTI, ultrasound done, and MCLG, and receive antibiotics and improve. What is the next investigation? So it is a question which come different time in different way. So I think you understand that it is very important. Even during my discussion, our discussion, topic discussion, we said it very important. So what do you think? It is 5 months. So and there is Proteus, so it is not typically E. coli, and already ultrasound done, MCUG already done. Child is improved. So what is the next investigation? Um, so when atypical UTI, then you have to do the DMSA. It is, you have to do 6 months after, but you have to do the atypical UTI, recurrent UTI, you have role of DMSA. Okay. So DMSA should be here. So do you think differently? If we just check it, what is the question here? Just I'm opening the UTI portion. So here you will get atypical UTI when 6 months to 3 years. Okay. So in that cases, DMSA is must things. Okay, for atypical UTI, must at 4 to 6 months. There is no confusion with this. Okay, even over 3 years, in that cases, atypical UTI having DMSA, no. Okay, not required that time, but as up to 3 years, you have to do this. So you can understand. Otherwise, also, I mean, this is the things that you have to repeatedly see. Atypical recurrent UTI, both having DMSA must up to 3 years. Okay, so this is the things. From here you will get one question. Now, polyuria, polydipsia. I mean, I think you understand these things, and your response is also there. Very nice. Now, polyuria, polydipsia with RBS 21. So you see, RBS 21. Okay. So sometimes we read, but we could not take it. I mean, our preoccupied some thinking could be there. Polyuria, polydipsia. So RBS 21, and you are reading it's 2.1. It could be happen. It's happened with me, so it could be happen with you also. Careful. P 7.2, bicarbonate 11, BP 9050, peripheral pulsation failed, CRT less than 2 seconds, potassium 3.6. What is the best management to start with? I have to share it. Okay. So I just want to say that do you get the diagnosis, whatever the management, because management is easy. It is management. You get the diagnosis here. So it is decay now. Diabetic ketoacidosis. Not same topic of us, but still. Um, so any tachycardia is there or not? It is very important. If there is no tachycardia, if there is tachycardia, then we will go for 20 ml per kg normal saline. I mean, tachycardia is the here important things. Otherwise, 10 ml per kg normal saline. So I don't get any tachycardia. So, and then newborn day one, I think from where the January, I will add that these things, okay. That January question started from here, maybe. I will add these things from where the January question start. Or maybe from here. Yes, I get it. From here, the January question. Okay. January 2024, okay. Newborn day one entered the scan at 20 and 32 is showing bilateral dysplastic kidney and oligohydramnios. What is the next step in the management? So it is bilateral dysplastic kidney, and there is oligohydramnios as well. So what investigation you want to do first? Anyone want to do anything? So they didn't say us that it is the bilateral polyhydramnios, but you have to understand these things because antenatal scan, why they did this, must be there is hydronephrosis, okay. So, and when there is a bilateral hydronephrosis, then your task is first your task is to start prophylactic antibiotics and also the then postnatal ultrasound within 48 hours, and they always avoid these prophylactic antibiotics, okay. So here it is, you have to take the B is the right answer, urgent postnatal ultrasound. So it's not written there. Okay. Then 12 years old girl has edema and swelling of both ankle extended into lower limbs to mid shaft and eye puffiness with headache, high BP. She shows LVH. Lab shows low albumin, proteinuria, hematuria, P-ANCA negative, C-ANCA negative. That means vasculitis excluded here. Complement level normal, immunoglobulin normal. What is the most probable diagnosis? So what do you think about this question? So it is 12 years girl and there is generalized edema. Um, yes, generalized edema along with very high BP with proteinuria. So GN features is there and they didn't say us which kind, how much the low albumin, but it's a nephritic presentation. Okay, along with LVHY because of high blood pressure. So what do you think? IgA nephropathy, focal segmental, post-streptococcal, or minimal change or membranoproliferative glomerulonephritis. Okay. Okay. Um, so actually, here focal segmental glomerulonephritis usually their presentation is steroid-resistant nephrotic syndrome, and when we get that the child having there is GN features along with some proteinuria is also significant. In that cases, usually it goes in favor of membranoproliferative glomerulonephritis. So I just want to choose membranoproliferative. Again, very difficult to differentiate. Here we have to do the biopsy actually, whatever. But from the presentation, I want to go for membranoproliferative glomerulonephritis. Okay, timing is actually 8 p.m. What about others? I said it now, 8 p.m. So first initially 7:30 p.m. but I see it is very difficult for me. So after prayer and something, the preparation is so difficult. So I take it 8. Uh, where is other numbers? Okay. So whatever, you have to be very much active. Otherwise, yeah, I mean, for every exam, we have to be very active now. Otherwise, very difficult. It's not very easy exam. Okay, 14 years old, polyuria, polydipsia for 4 months, passes of 6 liters of urine per day, all labs normal, serum sodium, potassium, osmolality, RBS, and urinary osmolality. What is the diagnosis? So it is DI related. I make it very clear. So I hope you can understand these things. In previous lectures, I make it very clear. This is a very common questions. You get it. More recall like this. Um, so you're thinking what could be? Is it showing changes? Oh, no, no, no. I'm so sorry. It's not showing. I think yes. Mm. So this is the thing. So what is this? What is your diagnosis here? So impulsive water intake. Thank you for your right answer. Because you see, hypernatremia is not here. So you're not thinking of that it is a DI related. Whatever urinary osmolality is very low. But when the impulsive water intake is there, because sometimes they didn't say that impulsive water intake, but they can say just that is CP charge. So impulsive water intake only possible. So those who are not, conscious, or orientation is not there, or child is not having some psychological problem. Okay, so remember this point, because some recall it's slightly different. So 9 months old with early morning eye puffiness, pedal edema, improved during day. On examination, there is periorbital swelling, ascites, mild pedal edema, heart rate, respiratory rate, BP 90/40, investigation, albumin, very low creatinine, very high protein creatinine ratio 330, very high. What is the first step in the management? So you want to go for nephrologist or not? Urinary protein, or give 20 ml per kg normal saline, or albumin 20%. What's your first step? It is only 9 months old now. But for this child, is there anything serious? Heart rate is normal, BPO normal, creatinine is high. That is very normal for the child. Okay. So I just want to say how you are thinking. Um, Maybe Dr. Fahmina is writing to you. Okay. So discuss with the nephrologist is there, but it is the nephrological referral is very right that you will send for nephrologist referral. But infantile nephrotic syndrome, you can start prednisolone. Okay, it's not like that without. I mean, you have to refer, but it's not like. I mean, here you will send the patient with the ambulance. It's their question is different. I mean, question here type is very different. Okay. The question is for first what you want to do. So when the child having atypical presentation, we'll refer the child with the things, refer the child, but we can start prednisolone now. And you will start discussion with the prednisolone, I mean, with the nephrologist. It is written in the pediatric guideline that your discussion will start when child is not responding to the steroid. In that cases, although it is registered nephrotic syndrome after 4 weeks, but you can start your discussion early. But these kinds of patient, you can start prednisolone, but you have to refer the patient. So and then they will take the patient. But here not albumin or protein, but you have to discuss. But question is the first step in management. I think it should be prednisolone should be start, then a discussion with the nephrologist. So, Dr. Khanij, you said it for the first question, now. I mean, for May 2023, this question. So, from my point of view is infantile nephrotic syndrome, we can start and we will have to refer. So, after referral, you will stop management or you can give prednisolone. This is the point. So, we can give the prednisolone, but we have to must refer this patient. There is it's fulfill the criteria, but they ask you what is the first step in the management. The child having no problem now, other than high creatinine, so it could be due to dehydration even. Everything is favorable. So nephrologist referral is must, but we can start prednisolone. Same type of question. Another one is having same type of question. They in that question, you have to start prednisolone. It's very clear. Okay. If they give you that, what should be your what is your management? What is your most important management? Then you will go for discussion with the nephrologist. But you have to start prednisolone when the child having nephrotic syndrome, and you can refer also. But for these questions, I have to, I will again check the pediatric guideline, anything he wants to say, because I have some nephrological, experience. So my tendency to start prednisolone always. So these things not comes to my mind. You know that sometimes your experience could be harmful for your exam even, because this is a UK is not needed any experience or you knowledge. You just they just need that you are following their rules. That's the things. Okay, so we just keep it here. Okay, and I think I will again check it out that discussion would be first, or prednisolone would be first. Okay. So serious most common complication within the first week of 15 years old boy, pictures of older child with a rash and buttock, back of thigh and forearm. So what do you think that, this is a question which I must debate, and I find it, I search it from various source, and what I get that it is not written directly that what is the most common complication, but they write it that renal complication is not common for the HSP patient, and you can see this child is HSP by seeing these pictures. You should keep it in. You should have this suspicion. Must your priority suspicion is HSP. Okay, Novosconin purpura. With a rash on buttock and back of thigh. Yes. So renal complications is there or not here? Maybe they write it retinal hemorrhage, GIT, pulmonary hemorrhage, hypertensive crisis, hemarthrosis, and septic arthritis. So it is easy, but another same recall paper you will get renal failure. Okay, so here renal failure is not an option, but same question having renal failure as well. So for this question, we don't want to go for renal complications or renal failure because it is quite uncommon, renal complications. And then if they give you like arthritis or arthalgia, then you should go for the most common arthritis. Arthalgia could be, but again they just write it hemarthrosis, which is not common, septic arthritis, which is not common. There could be hypertension, but hypertensive crisis is not common. Pulmonary hemorrhage, again very uncommon. Retinal hemorrhage also very uncommon. So remaining is GIT hemorrhage. So do you think it could be different? What's your thinking? So now everyone is admit with me. Okay, that's great for me. So if you differ, it's also great, more than great. So it is not hypertensive crisis. Okay, I will review these things. It should be GIT. So be careful, I'm changing something. So you have to know the most common, commonly what is, okay, the latest thing you should have idea. Now, 5 years old presented with 3 episodes of painless frank hematuria over 4 months. 2 attacks were associated with recent upper respiratory infection. The last one was associated with non-blanchic maculopapular rash. What do you think? 3 episodes of painless frank hematuria over 4 months. attack were recent upper respiratory infection. The last one is with non-blanchic maculopapular rash. So so you get it that the question presentation is different. Huh? Okay. Then 5 years living in farm presented with non-bloody diarrhea, dehydration. For this question, what you are thinking? First, complete these things now. Yes, so this is the IgA nephropathy. You see that IgA nephropathy, we first discussed with one question. Just I have to, I want to, I mean, someone joins lately now. They should see these things. Here we are very much confused with the Alport and IgA because they have relative stiffness, but they just say you that hematuria. So for this question is different. There is recurrent, I mean, there is recurrent same type of problem now. Okay. So here also recurrent same type of problem, and last one was associated non-blanching or whatever. Some rashes could be like it is indicate HSP. So you know HSP IgA nephropathy is similar. Sometimes they could have some similarity, and also HSP nephritis when you in the biopsy reveals IgA deposition. So it should be IgA nephropathy. Then another question, 5-year living in farm present with non-bloody diarrhea, dehydration, oliguria, high urea, creatinine. So there is diarrhea, but it's non-bloody, whatever. CBC blood films were normal. And there is child is 5 years and living in farm. Okay. So what do you think? High urea creatinine, but CBC blood film were normal. Okay. So when the blood films is not normal, so it's not support our diagnosis that we should want to do here is like HUS. So HUS having Julfikar joins. So yes, Dr. Julfikar, I was thinking of you. Why you are not here? Okay. Okay. So I was, I mean, CBC blood film were normal, then we can exclude it. Otherwise, everything in favor of your HUS. You see, living in farm, it's indicate HUS, even high urea creatinine, oliguria, dehydration, diarrhea. But when the CBC blood film is normal, it cannot fulfill the criteria of HUS. Okay. So we had choose rotavirus induced GI. 3 years present, 2 months history of frank hematuria, fever, irritability, parents notice in case abdominal gut, otherwise patient asymptomatic, another examination is normal. So what is it? Frank hematuria, and there is ascites also. Other is normal. So there is no problem other than I mean abdominal gut is increased with hematuria. Is there any relationship with DKNO and not HUS, not HSP, not nephrotic syndrome like this, IgA nephropathy, PSG, and drug-induced nephropathy or renal failure? So Wilms tumor could have, they can present it with simple, only for the some mass in the abdomen. Okay, so Wilms tumor should be here. So but it is interesting now. Even these questions came like this way. Painless in case abdominal fibrosis, incidentally neonatal hypoglycemia and operated omphallosis. So what does it mean? It is Wilms tumor. But which syndrome they wants to indicate, because the question will not always like this way, na? Wilms, if you say Weger syndrome, then Wilms tumor anidida genital abnormalities. So it is not Weger syndrome, but Wilms tumor associated with two syndrome. One is Weger, and another is Beckwith-Wiedemann syndrome. Beckwith-Wiedemann syndrome would have omphalocele and neonatal hypoglycemia. This is a very common question, invariably asked in the exam. Okay. So you get it. What other things? Hypoglycemia, omphalocele, yes. Even it is common in the, I mean, there is in the genetics chapters, you will get these questions again, okay, but different way. Child has sore throat 10 days ago, now presented with edema, hematuria, proteinuria, high BP, high creatinine, hyperkalemia. ECG shows peak T-wave ST depression. What is the best immediate action to be done? Sore throat, now edema, hematuria, proteinuria, very high BP, high creatinine, very high potassium. Whatever. I mean, you have to give something very urgent. So you have to give the yes, calcium gluconate. I think this is also in the part 1 exam. So calcium gluconate you have to give immediately. Patient with recurrent hematuria, mother has hearing loss and using hearing aid. Patient has some hearing difficulty, proteinuria, hematuria, CTC for normal, high urea creatinine. What is the diagnosis here? Recurrent hematuria, hearing loss, hearing aid. Okay, so you get that how the question pattern, okay, how the question pattern for L-port. So remember the question pattern. Okay. I think it's very obvious. Not only family history, a child also having hearing loss. Mother having hearing loss problem, child also having hematuria, high urea creatinine is there. So you have to understand how the I don't know. They are here goes L-port and IgA. Okay, so why they like it for AKP exam? L-port IgA. Remember. Okay. Other things. I mean, some red mark maybe there. I should go for this. Here, 180 questions. Okay, so we can just check more some question. Bed 4 to 5 minutes per week. Continuing till age of 5 years old, parents used to wake him up to the bathroom every night, open his bowel once every 2 to 4 days. Yes, no data minko, no days, no sharing with his brother. So what do you think? So there is open his bowels once every 2 to 4 days. It indicate that constipation is there, but there is main problem is nocturnal enuresis. You see, bedwetting is there at the age of 8 years, but it was recent onset because up to 5 years it was okay. So you want to start DDAVP, amitriptyline, oxybutylene, whatever. So I'm just want to check you what you were thinking. So yeah, macrogal. So if any problem there, then you have to treat it first. Then you can go for the aneurysm treatment. Then next question, 5 years old boy vomiting, fever, discomfort, and had proteinuria edema. He take prednisolone and was steroid responsive nephrotic. Now stop treatment, come with 2 weeks puffiness, swollen abdomen, proteinuria, respiratory rate 35, pulse rate 140, shallow rapid breathing, poor air entry bilaterally, tender distended abdomen, investigations, hemoglobin there, total count 24. Normal 18.8. So what is your thinking? Yeah, it's so different, no? The totally the way of presentation is totally different from the part one exam. No? You see what they say that child is on a steroid now, child having rapid breathing, and there is a tender abdomen. So you are thinking of total count is very high. So you're thinking of peritonitis. So I think it's easy question also. 10 months infant present with abnormal movement, not smiling to his parents in previous days. He's 26.4 kg. He's passing wet nap, still not dehydrated. Urine output in last 12 hours was 400 ml on examination. Infantile spasm on MRI showed hollow prosencephaly. Sodium very high, other was normal. Serum osmolality is normal, but urine osmolality very low. So there is some brain abnormality and then urine osmolality like this. So correct electrolyte disturbance. What is the? But you know that it's the what is the diagnosis when the child having weight loss and there is whether there is polyuria. Okay, still not dehydrated, but he is passing wet nappies. Weight is 6.4. So weight loss is there now. Previous days his weight is 6.4 kg. Okay. There is infantile spasm, MRI show hollow prosencephaly. Okay, so your diagnosis, you get it that you have to know the diagnosis as well because of it is a case of DI, na? And it is central DI. Okay, so what you want to go for this patient? It's important things. International desmopressing, you have to go. But is there anything, I mean, if in the presentation, if you get that there is shock, that is different issue, but it's not mentioned here. Is there any things I put it here? I mean, important things. Here, what they ask you, healthy, well grown, and history of red brown urine parents, he had solenized lower limb, had you treated at home with paracetamol fluids. He developed headache and vomited paracetamol, blood staining fluids. He developed general convulsion for 10 minutes. So there is a prolonged convulsion status. But there was, it is like their presentation is like acute post-structural glomerulonephritis. Okay, so child is, I mean, thirsty and they give fluids, yep, and headache and this types of problem. Glasgow Coma score is was 11 and normal fundus cranial nerve. So there is, they want to say that there is no papilloedema. Their brisk reflex in the lower lip and hypertonia and positive ankle tonus. So upper motor neuron sign is there. Urine examination 3 plus protein and blood. What is the question here? So what is the cause of convulsion? So there is some changes in the lower limb. It's indicate that so some lower limb upper motor neuron sign. So intracranial some problem is there. So whatever you know about press, due to high blood pressure, there could be reversible encephalopathy. Okay, posterior is usually posterior part of the brain is involved. Okay, and it is a one kind of encephalopathy due to high blood pressure. In that cases, you can sometimes get only the MRI features, or sometimes you can get some upper motor neuron sign in the lower limbs also. So it's post-structural glomerulonephritis along with hypertension, and your systemic hypertension is the cause here. Okay, so it's not like HSP, encephalitis, cerebral abscess. The cause of convulsion is systemic hypertension. Okay, so but actually the scenario is the press. Press important cause in case of child. It is the I mean. I think there is no question with the press. I just tell you that with the high blood pressure, why this child having upper motor neuron sign in the lower limb. Okay, So post-reversible encephalopathy syndrome. Okay. Then it is shown or not? Is it still there? I think. Yes. Okay. Now, okay. Now, so and you see that there are less question in the previous year, but nowadays from nephrology you get a lot of question, a lot of question. So you see it is January 2022, but within this time less question of 2022. But you get a lot of question recently. So this time I took nephrology first. 6 weeks old boy scattered spots in the legs and buttock. 2 days ago, pain in the right ankle was treated in discharge. So there could be HSP now. 1 week later, come with follow-up urine done, and initially B was 90/60. What is the most important needed to be done? Urine done, and urinary any abnormality was there or not? It's not mentioned here. So what you want to do with this question? So for the HSP, you have to continue at least 6 months one test. At least 6 months you have to do the one test. Okay. So this is the urine analysis. Whatever urine become normal now. Okay. You have to continue the test monthly. That is the urine and blood pressure. Okay. They will continue follow up to 6 months with blood pressure and urine. So after then they will be discharged. But in the HSP patient, when you get that, there is urine, blood pressure is raising and creatinine is high. In that cases, you will refer to the nephrologist. Not every patient have to be referred to the nephrologist. It's not like that. Renal function test usually not required until indicated. Okay. Now this question, 3 weeks offensive urine, total count in sample 100 into 10 to the power 6 weeks apnea, persistent cough, WBC 17. So it is very easy question. 3 weeks child having offensive urine and you get high WBC count, you have to think over. You have to think over the UTI, and for 3 weeks you will not give any oral drugs. What antibiotics you want? Less than 3 months, IV cefotaxime, all kinds of, UTI means it is a late onset neonatal sepsis, and you have to go for cefotaxime and amoxicillin. Okay. And next question having, here, cough with WBC 17, lymphocyte is high, and it is only the 6 weeks. It's a classical time of presentation of whooping cough. And for the whooping cough, what management you want to give here for the 6 weeks? Oral clarithromycin, okay. And then 8 years left loin pain, dysuria can take orally, clean catch WBC. What is this? 8 years left loin pain, dysuria can take orally, clean catch WBC more than 90 to 10 to the power 6. WBC count is high, left loin pain, dysuria. So UTI is there. So, but which kind of UTI? There is left loin pain. Dysuria is there, can take orally, clean catch WBC. If they don't give you like high only loin pain, not always confirmatory for acute pyelonephritis. Dysuria is there, lower urinary tract symptoms is there. They didn't say you fever or something. Maybe in the question paper you will get the child have no fever or something like that, child vitals stable. In that cases, you can take here it is as a case of lower urinary tract infection, and you can think of oral cephalexin. Okay. So it should be actually not IV cephalexin, it's oral clarithromycin. Okay, so if it is like write it that if it is like write you that clarithromycin is not you can't give, and then you can go for the azithromycin. I mean, for very sick patient, you can go for the IV azithromycin also. And child having apnea, you see, any kinds of IV azithromycin here? No. Child having apnea also. That is a classical presentation of whooping cough. So I just want to check that anything important. Again, antenatal scan having bilateral dysplastic kidney. You see, it is totally a repeat question. Same to same. So metabolic alkalosis, it is also same question. Okay, very repeat question, and I mean this one also is different. So there is hyponatremia, and you see patient having cough distress, bilateral pitch crackles, that means pneumonia, 11 months, and vomited 5 times, all labs normal. What is the cause of hyponatremia? So with the pneumonia having hyponatremia, what do you think? Is it Bartter, pseudobarter, recurrent vomiting, or other than this? When pneumonia-like presentation, meningitis-like presentation, along with hyponatremia, you will think of SIAD. Okay, very right, SIAD. It is again very repeat. Okay, very repeat presentation. It is again we discuss these things with the UTI. Okay. So please go through, I mean, these things very carefully from the PDF. That here simple UTI and 6 weeks time urinary dysplastic kidney confirmed by the DNA said that other kidney is normal. So further management. When there is, I mean, simple UTI, then you need not to follow up or anything. But it is for the dysplastic kidney, you have to go for something like it's called, you have to follow up with the, okay. So no need of nephro or MCOG. This child having UTI, which is typical UTI, simple UTI, maybe ultrasound done at 6 weeks because of their age, maybe less than 6 months, typical UTI, so ultrasound can be done lately. And in that cases, dysplastic kidney shows, and unilateral dysplastic kidney means you have to follow up in the, for the blood pressure. It is a new scenario actually from the above scenario. It is very much common scenario of HOS. Scenario about 7 years child with nocturnal enuresis with daytime symptom. So for nocturnal enuresis, we can give, I mean, reward and something, offer alarm system, many things we can do. But oxybutynine for the daytime symptoms. Okay, if there is oxybutynine, then we can offer oxy. Sorry, when there is daytime symptoms, we can offer oxybutynine. So 3 years old girl, when you get mixed culture, mixed organism in the urine, it means they indicate it's like you need clean catch. Okay, mixed mean organism means it could be, I mean, some contamination is there. Okay, so but it is rated 3 months, so it's called less than 3 months, then suprapubic. So it is also a, I mean, repeated. Okay, so hematuria, glycosuria, proteinuria. And this question may be new. 28 weeks gestation unit with history of trauma for 30 hours. Patient is 12 hours old. Umbilical artery catheter, umbilical venous catheter inserted. Now presented with oliguria, high BP, and investigation very low hemoglobin, platelet flow, creatinine high, urea high, urine analysis, RBC, hematuria, proteinuria. What is the diagnosis? There is something for renal vein thrombosis, but you see, because of catheter insertion was there. Now high blood pressure. And hematuria should be, because we know that hematuria, hypertension, and also the mass in the abdomen. So the kidney could be enlarged. Anything for ultrasound? No, but we can go for the renal vein thrombosis. So here, from here, I can check for some red mark, because I always, so you see here again, LPGN related question. It was my, okay, this my repeat. Alport syndrome related again question. Okay, yes, you can check. It is a question of debate. Okay, so you see, it is May 2021. This is my FAP exam. Okay, so I know this question very well. 9 years old girl, fever, was found to have glycosuria but no history of polyuria or polydipsia. Her fasting blood glucose level was 4, normally 3 to 6. Fever subsided, but glycosuria persisted after the infection has resolved. What is the next step to clarify the cause? Okay. Polyuria, polydipsia, glycosuria, blood glucose level normal. But glycosuria persisted after the infection has resolved. So what is your diagnosis here? So it is a renal glycosuria. Okay. Because sometimes with fever or stress, they could have glycosuria, but their sugar level is normal. In that cases, you can think of this. You can think over the renal glycosuria. Okay. And you have to be. If you go for the intensive study of this, there is something called. In the books, it is not written. In the SOPs or other books, I didn't get it. Even not in the pediatric guideline, but Medscape something is there. So renal glycosuria, if there, then you have to first do the oral glucose tolerance test, and then you have to confirm that how the sugar is behaved. Normally, oral glucose tolerance test only done for the cystic fibrosis patient who having, you are thinking of, it could be diabetes could be associated. In that cases, OGTT is done, but for diagnosis, we never did. It's mentioned that OGTT is not required for diabetes mellitus. Okay. And also you have to do the insulin, urinary glucose, glycosylated hemoglobin, okay, all of your urinary sample. So here you have to do the oral glucose tolerance test. 75 gram is the right answer here. 75 gram oral glucose tolerance test. But paired fasting glucose with insulin, not for this condition. Okay, it's different condition. I maybe write it here. Oh, okay. So I should mention oral glucose tolerance test. Okay. It came first time in the May 2021. After then, they never give it. Sorry. So remember this point. So anytime they can give it. Okay. Um. Okay. So it is again very common scenario like this Fanconi. We will discuss this imaging related things in our hematology chapters. Okay. So the how can we differentiate hepatoblastoma, renal problems, and other things. Okay. So I didn't discuss these things here. So again, we will discuss same things will be there also. Um, then it is UTI related. So you will read this every question simultaneously. Okay, UTI related. Imagine. And I think it is also very common scenario that we are okay. So it is okay. It is slightly different. So it is a baby who born preterm, 32 weeks, having at 5 years having low in pain, and ultrasound showing bilateral nephrocalcinosis, calcium creatine ratio high, so it is idiopathic hypercalciuria. Okay. So when the calcium, there is stone, in that cases, it could be associated with this renal tubular acidosis. Williams syndrome is related with hypercalciuria. Okay, but William having some symptoms will be there with the William. William having very large face. They are very chatty, happy, playful. Okay, so it's not mentioned here. So it is a idiopathic hypercalciuria. Why hypercalciuria? It is not here. I mean, not always we get it. So it's called idiopathic hypercalciuria. But underlying cause could be hyperparathyroidism as well. Okay. Here another question. It's um, mm, so it is repeat question that is confusing. Okay. So same questions came in the exam. Yeah. I said you that HSP related that is a most serious complication in the first week. There are some questions like this, and it's not acute renal failure. It is GIT hemorrhage. Okay, because renal failure is very uncommon, and within the first week is more uncommon. Other than it is also a repeat topics. Okay, and you see that it is now very easy. I mean, after discussion, it is now very easy for you. So, not red mark is still necessary. So it is taken from directly from the sample paper question. Okay. So please go through the sample paper as well. So it is a case of known case of SLE. I can remember the question in my, I mean, totally. So it is a, SLE patient, and you get very high BP, and their renal function is also impaired. So SLE patient could have renal dysfunction. They having thrombocytopenia even. Potassium is 3.2 low. Metabolic acidosis is there severe. So bicarbonate 10 only, base deficit sequence -6. There is bilateral pedal edema. So having SLE with SLE with renal dysfunction, all the features is there. Child is on antihypertensive drugs, but poor compliance. So what two steps you can take. When there is a blood pressure 160/100 and there is a tachypnea, also tachycardia, and there is a bilateral crepitations, it means heart failure. So what management you have to take? So it is actually very well-known question. And I mean, directly they take from the sample paper. Okay, no change. Okay, so you have to give the furosemide now. You have to save the child from heart failure. But here no hyperkalemia, So calcium gluconate having nothing, you have to give it. I mean, it is written, no. But you have, if you give the hemodialysis, then their blood pressure also will be reduced. Their creatinine is high. So you see creatinine, it's not like, I mean, very high, 500, 555. So it's very high. And child having metabolic acidosis also could become normal. Child having edema, and it is chronic. I mean, the child having chronic problem. So hemodialysis will be worked on. But hemodialysis doesn't mean CKD only. Even acute, if a acute requirement, then they give hemodialysis. IPD is not available in. I mean, IPD is not done in their settings usually. I mean, in the developed country, until there is a mass disaster, so hemodialysis is not possible to give. So in that cases, hemodialysis is better option for them. Again, this question is from UTI related, so I don't think it is required too much discussion. So they love to give question from UTI, you see. Premature baby could be having nephrocalcinosis, idiopathic hypercalciuria. It's very important. I think here if there is something confusing question, must be writing. Red marks will be there. So I think we did discussion. So in the next day, we will try to do, I mean, other things. That is the cath is remaining there. So it depends how much required for you actually to repeat a cath cath live class, or you just comfortable with the recording one. So you can write it in the group so that I can understand. Other than this, you just complete the nephrology. Okay. From the next, we will do the cardiology and GIT. But I think we will, a case of postnatal valve, same. You have to go for an urgent postnatal ultrasound. Okay. So yes, that would be very nice if you ask some questions. Actually, that would be very nice. There is a with you. I mean, there is in the just last batch. There is a one doctor from Pakistan and working in Saudi Arabia. She is very enthusiastic. She mark all the questions and ask the questions. Even in the last FOPTAS exam, she did it. She was first gave AKP, then gave the FOPTAS. So it was very nice for me. Okay, because she's very prepared. Okay, so what I say that urgent ultrasound. Okay, when there is a bilateral hydronephrosis, or this is a condition of, I mean, there is posterior valves means there is bilateral hydronephrosis. No? Anything more? But caution, never you get prophylactic antibiotics. But remember, when there is prophylactic antibiotics, you will take it first because it is something like urinated abnormality means after birth, you will give prophylactic antibiotics. And then if it is bilateral hydronephrosis, you will go for ultrasound within 48 hours. And then you will exclude the posterior valves. If it excluded, then you can go for stop antibiotics. Okay, then repeat ultrasound after 2 to 3 months. And if it is they are posterior valve means you will do the operation. So you will refer the patient to the surgeon. So theory exam. So theory is much needed. Okay. Some theory we have to know. So anything more? No. What I said that write it for if required again a cath class live or just if it's not required then it's okay. If options are MCUG and serum electrolytes. So serum electrolytes is actually important, but it's never mentioned in the pediatric guideline that we have to go for serum electrolytes first. This is important for congenital adrenal hyperplasias. Sometimes we become confused with these things. Okay, in that cases you have to go for serum. Hyperkalemia could be there, and it is alarming. There could be hypoglycemia immediately after birth. You have to go for these. So in the guideline, we didn't get these things. Serum electrolytes. MCUG, you can't go for the MCUG before you confirm that the child having active UTI. So yes, pediatric guidelines said less than 1 year, more than 12 years. I'm very much, oriented with these things. But I'm just saying that, can we start with, pediatric steroid and then discussion? Or it would be the first step if it is written by this way. Okay, that you have to refer the patient, so we will take the nephrologist referral. Okay, but here you see discussion with the pediatric nephrologist and prednisolone also a option. So referral also could be, but just I have to check a little bit. Okay, then I will also discuss with you. Referral to nephrologist less than 1 year, more than 12 years, very sure. But prednisolone could be start. Now, we started like this way. In the infantile nephrotic syndrome, we started and okay, so I will discuss with these things. Just I have to check a little bit. And Dr. Rejwana said September 2017, question from September 2017. Okay. September 2017, maybe later. Where is 2017? Oh, 2018. Then, it is the last question. Do you want to mention it? September 2017, May 2018. Okay. So, May 2018. Okay. January 2018. Oh, come. A term baby with mass and umbilical artery catheter, venous catheter insert initial hematuria protein plus renal vein thrombosis. Very right now. But I think you didn't mention these things. These very easy things. Most urgent action. Maybe I missed the question. It is not like it is. So you see, May 2018, it is for renal vein thrombosis. Why do you get these things? I'm very sorry, I didn't get these things.
It's on May 2018 that a case of posterior valve
Mm-hmm.
most appropriate urgent action. And the
Mm-hmm.
options are MCUG and electrolytes.
This is the fallacy. Okay, so most urgent action. Electrolytes is never mentioned. So we can hear if only two options. So what is the other options? I mean, I think here they could not recall appropriately. So they here urgent ultrasound is there one of the options. So you can be very sure that ultrasound will be there because all the questions you see, ultrasound is there. But if somehow the question is like, um, it's like you said, so in that cases, I don't want to go for electrolytes because it is not invariable posterior valve patients would have with electrolytes abnormalities. It's not very common. I mean, they would have some problem and it takes time to be renal failure and then the hyperkalemia will be appeared. No? So I think antibiotics will be the better option. Get it? Okay. Okay, thank you. We'll meet you soon. But another one from what do you mean by Rejwana Rifat? January 2023. Okay. January 2023 should be later. Yeah. So learning difficulties with 24 hours of vomiting, drowsiness, sodium is 180, potassium 4.3, chloride 130, uric acid normal, urine osmolality 180. So what is the most likely diagnosis? When there is a sodium more than 170, then we have to think over the salt poisoning could be an option. Okay. But yes, it could be diabetes insipidus. So where is the problem? Urinary osmolality 180 and sodium is 180, very high. Potassium is 4.3, chloride 130, and there is a learning difficulties. So when there is a learning difficulties, then there is high chance of salt poisoning, actually. But more than 170 urinary, so more than 170 when serum potassium, sodium, it's indicate that there is high possibilities of salt poisoning. Okay. Um, and next step of management is not mentioned here. That what is the option? So salt poisoning. Yes, salt poisoning. I think, and some same type of question also there. Okay. Remember, more than 170. Usually, DI patient hypernatremia is there, but it's not goes even the, 170 usually. And they said learning difficulties, maybe this child having take some salt, they could be CP or something like this. If they wants to indicate something like a cranial problem, or they don't mention it. Okay, so salt poisoning is the option. Okay. Anything more? So take preparation for the GIT. You know, a lot of question, even for the last exam. I see that question is from all the questions from GAT. I don't know a lot of question why they love GAT. So I don't think that we can cover two topics in one day. I try to cover it within the April. Okay, I mean within the April months, I will try to, maybe I will increase the class or something, whatever needed. So my focus is now only the AKP for the months of April, AKP examining, and I try to cover this. So most important things here: nephrology, neurology, cardio, and GIT. These four topics will be separate. After then, we can take it. I mean, interview. Okay, thank you, everyone. If you have no queries, then we can stop here and start reading. I'm not sure. Whatever possible, I will do, Dr. Khanij. I mean, I will try my best. You can believe on this, inshallah. Okay. And I said that I will cover it within the April months. So my target is to complete it April months. So, and you see that I mean, in one class we'll cover 1, 2, 3 topics, then maybe require more classes even to complete it. Okay. Thank you. Assalamu alaikum. Good night. You can take leave. Okay.